In this module, we'll review the central venous catheterization complication and defense through manometry of inadvertent catheterization of an artery instead of a vein. This complication can lead to additional vascular injuries, including but not limited to catastrophic hemorrhage, air embolism with neurologic injury, thrombus formation with possible embolism and neurologic injury, aneurysm, AV fistula formation, arterial occlusion, hematoma with airway impingement. This is an unacceptable complication that tends to occur when manometry is not used. Your defense is manometry with placement of the guide wire needle or catheter prior to placement of the guide wire dilating over that guide wire with placement of a larger catheter. There are generally two methods of manometry available. In this first example, the internal jugular vein has already been catheterized with a Jelco in preparation for guide wire placement. The vein's been accessed, and prior to starting the procedure, simply a IV extension tubing has been added sterilely to the field along with a stopcock and a 3cc syringe or a 10cc syringe. In this case, once the catheter is in place and before placement of the guide wire, one simply occludes the end of the catheter and goes down and connects the male end to the catheter. The stopcock is closed to prevent airway embolization prior to this step. A column of fluid is then simply pulled back with the syringe. The IV extension tubing is then raised and open to the atmosphere, watching the column of fluid, which should drop if indeed this is a venous access rather than an arterial. If it is arterial, one would expect the column of fluid to shoot up through the extension tubing. One then simply closes off to atmosphere the whole unit, disconnects, and completes the procedure. In the second example, prior to starting the procedure, sterile pressure tubing has been introduced to the field connected to a monitor and is ready once the vein, subclavian vein in this instance, has been accessed with a needle, and prior to dilatation or guide wire placement, one simply connects up to the needle without changing position and then checks for a venous waveform.